Hi everyone, I'm Chaz and I'm acute neurosciences clinical specialist physiotherapist based in Oxford. Thank you so much for inviting me to talk to you today. Neurocritical care, are we ready to extubate? I've certainly been asked that question a few times in my career, and I think the first thing that indicates is that it's not a decision we make in isolation. It's definitely an MDT approach. So I know that we've just heard from Arun, who's spoken to us about some of the complexities with the neurocritical care patient group. So how do we determine whether patients are ready to extubate in neurocritical care? It's a challenge I certainly faced when I first started working in the setting. I'd kind of come from more of a general ICU setting, and some of the clinical reasoning skills I'd developed as to whether somebody was suitable to extubate in terms of, has the primary reason for the intubation been reversed? Have they emerged from sedation? Is their cough nice and strong? And are they demonstrating signs of tube intolerance? They sometimes help with our patient group, but they can pose challenges as well. Some of our patients don't emerge from sedation or their head injury in the way we'd like them to. And coughs can be weak, they can be absent, they can be variable. And some of our patients look quite comfortable with an obstruction in their airway. And so clinical decision making can feel a little bit like this in the absence of clear guidelines or evidence or objective measures. There are consequences of extubation either way, and you can't necessarily foresee them. Although we're not alone, we're not as isolated as this picture indicates. So I also think the complexity of the patients has increased on neurocritical care. If we think about sort of our trauma patients in the 90s, they had a mean age of around kind of mid-30s. The majority were due to RTAs, and not even half of them would have a CT head. Whereas trauma patients and head injuries now, they're older, they're in their 50s. The majority are due to falls, and the majority of them also have CT heads. So patient complexity is also increasing. So what do we think about and what do we look at when we're considering to extubate our patient group? And I've just created this. It's not a complete list, but these are just some of the things that we might think about and consider as to whether patients on the neurocritical care unit are ready to extubate. And the presence or the absence of any of these doesn't necessarily indicate whether you do or you don't. So, for example, if a patient is presenting with agitation on a sedation hold, it wouldn't necessarily indicate that they're not ready to have the tube out. It might mean that they need to have it out pretty quickly, but maybe they might need a clonidine infusion, or maybe if they're agitated by some of their lines and attachments or their C-spine collar, we'll look if we can reduce those as much as we can. The other thing that's not on here is we don't necessarily base our reasoning on pathologies or treatments, but it is worth bearing in mind. So, for example, if somebody's had maybe a base of skull fracture or extensive facial fractures, or some neurosurgeries involve an endonasal approach, so they access the brain via the nose, it's definitely worth knowing before the patient's extubated, because some of our treatment that we might want to use, for example, positive pressure use via a face mask or a nasopharyngeal airway, they might be contraindicated, and you definitely want to know that before you extubate. So I didn't really want to leave it there, that these patients are difficult and there's what lots we need to think about. I kind of, I suppose in some ways, speaking at the conference inspired me to try and get some more information for you. So we looked at our local practice in a little bit more detail, and I'm able to share some preliminary data with you today. So we evaluated our local practice here on our neurocritical care unit in Oxford and looked at some of the assessments we do, specifically in relation to physiotherapy, but also how our patients present prior to extubation and whether they succeed. So we completed a prospective service evaluation of 24 consecutive patients admitted to our neurocritical care unit between August and September of this year. We included all patients aged 18 years and above who were admitted to the neurocritical care unit with a central nervous system impairment that required intubation and ventilation. And we excluded any patients who were extubated on a palliative care pathway. So 24 patients in total, 46%, so 11 of the patients were female, and the majority of them, so that's 11 of them, were in the 41 to 60-year age group. The majority of the patients we looked at, so 8 of them had a traumatic brain injury, followed closely by subarachnoid hemorrhage. That was 6 patients, and 3 of them had a stroke that wasn't subarachnoid hemorrhage. So, of the 24 patients, 18 of our patients, so that's 75%, were successfully extubated on their first trial, so they succeeded. 4 of our patients required reintubation, so they didn't succeed their first trial extubation, and 2 of our patients, that's 8% of them, proceeded straight to a tracheostomy without having had a trial extubation. Both of those patients, well, actually we'll talk about those first, both of the patients that proceeded straight to a tracheostomy without a trial extubation were under the care of neurology, so they were not neurosurgical patients, and you can see there's actually a big difference with their GCS. They had a mean GCS of 5.5, you can see that their pressure support's a little bit higher, hasn't necessarily been weaned as the others have prior to their tracheostomy. So the biggest thing I noticed is this length of stay over here on the right hand side. You can see that patients who have failed their first trial extubation, their length of stay is almost double that of patients who succeed their first trial extubation. And actually these 2 patients who have had a tracheostomy, their length of stay on the neurocritical care unit is more than twice that of patients that don't succeed their first trial extubation. So of those patients that didn't succeed, I've just got the table at the bottom here. One of those patients didn't succeed because they were agitated, but they did successfully extubate on their 3rd trial. So that just shows that because somebody's agitated that first trial doesn't mean that they don't succeed on subsequent trials. 2 of the patients didn't succeed due to a neurological deterioration, and one of those successfully extubated on the 2nd trial, and the second one unfortunately passed away, and one of the patients didn't succeed their first trial extubation due to respiratory failure, and they were successfully extubated on their 2nd trial extubation. So there are outcomes for what I understand is quite a small patient group, but it would be good to look at larger numbers. So cough and tube intolerance. So we're really good, it looks like, at assessing coughs. All 24 patients had their cough assessed. And so the table here just shows whether that cough assessment, whether patients are coughing to command, spontaneously or on suction. So we're really good at assessing cough. What it seems we're not so good at is we're not always great at recording what cough strength is. And I was really interested in this patient group. So it's the top row here. So those patients, the 18, those 75% of patients who successfully are extubated on their first trial, you can see that 4 of them had a cough strength above 80 litres per minute. 5 of them had a cough strength between 60 and 80, but for 9 of the patients, we didn't record their cough strength. Now, they did succeed their trial extubation, so it could be, are we just really good at knowing a strong cough when we see one? You know, those patients, their kind of head lifts off the pillow, and it's really strong, and you haven't caught the vent, but you know it's strong and you're confident with that, so it could be that. Or what would be interesting to know is, because on the table here, none of these patients have actually got cough strength less than minus 60 litres per minute. We haven't recorded it. Could it be that some of these patients are actually successfully extubated and actually they have an incredibly weak cough? And we're not sure, but that would be something that would be interesting to look at. Those patients who didn't succeed their first trial extubation, for 2 of them, so small numbers, but 50%, we didn't record the cough strength. But for the remainder 2 patients, for one of them, it's below 60 litres per minute, and for the other, it's between 60 and 80. And yet both of the patients who underwent a tracheostomy, we did record their cough strength, and it was weak. It was below 60 litres per minute. So we seem to be better at recording maybe when it is low. Tube intolerance. I know Arun's spoken about this quite a lot earlier. It's really difficult to assess, and by that I mean difficult to assess objectively. It is subjective. It's what somebody sees when they look at the patient. So this was recorded via a simple yes/no. Did somebody note tube intolerance? or did they not? So that would be, are there any signs of the patient being uncomfortable due to the presence of the endotracheal tube? And we can see of those patients who are successfully extubated on their first trial, 14 of them demonstrate some signs of tube intolerance. So there's signs of discomfort due to the presence of the endotracheal tube. And yet, having said that, 4 patients don't demonstrate those signs. So they appear comfortable with the tubing, and yet they are successfully extubated, which talks about kind of Arun's work and research into having more objective and individualized assessments for these patients. What is it that kind of, about these 4 patients who are, comfortable with the tubing for what it seems, but actually are fine when the tube's taken out. And we can equally see with the patients who don't succeed the first trial extubation, 3 of those patients actually did demonstrate signs of tube intolerance, and yet actually ultimately didn't succeed their trial extubation. And both of the patients who underwent a tracheostomy were not intolerant of the tube. So we had a look at our physiotherapy practice. So the table here that shows pre-extubation physiotherapy provision, that where it says that last pre-extubation PT review, that's what treatment did they require prior to being extubated. So most patients, so 89% of them, 16 out of 18 who were successfully extubated, were seen by physiotherapy prior to being extubated. And most of those treatment sessions, so 75% of them, were airway clearance. So whether that be use of the manual hyperinflation bag, suction, with or without manual techniques. Fewer patients in that group underwent rehabilitation prior to being extubated, and that's 25%. And we can see the difference post-extubation. It looks like we're a lot quicker at seeing patients once they've been extubated. We see them a lot earlier, on average 4.6 hours following, and most of the most of those sessions, are rehabilitation interventions once the patients have been extubated. But 39% of those patients who successfully extubated on their first trial underwent some form of airway clearance following their extubation. Those patients who unfortunately didn't succeed in their first trial extubation, they're actually seen a little bit later than that first group that do succeed, on average 9.5 hours following their extubation. And probably not unsurprisingly, most of those patients, 75%, so 3 of them underwent assistance with their airway clearance, and fewer, 1 of them, a rehabilitation intervention. So future implications, I think maybe with a few changes, I'd definitely be interested in looking at our extubation practice and how our patients present and how we treat them, in looking at a larger data set. And I'd be particularly interested in knowing more about the cough strength of those patients who do succeed well and don't succeed, and just see, is it that we're just really good at knowing a good cough, or actually are a significant number of our patients successfully extubated that actually have a cough strength that we would determine is weak. And I'd also really be interested in looking at, we use the intensive care mobility scale, but looking at rehabilitation interventions pre and post extubation. Our staffing wasn't optimal during the time period in which this data was looked at, but we're soon to start a 7-day rehab service with 5 whole time equivalent staff on the unit. And I do wonder whether it seems that kind of physiotherapy practice seems to be divided into airway clearance or rehabilitation post-extubation. I'm wondering whether that's sometimes influenced by staffing, that you've got time to do one thing, maybe not both things. So I'd be really interested as to whether that changes in the coming months. Thank you so much for your time, and I'd especially like to acknowledge and thank the NICU physiotherapy team in Oxford for assisting with the data collection, and the Allied Health Professions Research and Innovation Unit in Oxford for assisting with the data analysis. Thank you so much.